All right, hi there, Scott Thomas, Regional Fellow here at the Andrews Institute for our block of the day. Today's video is going to focus on kind of a tips and tricks little segment today. This is going to focus on what happens when we have a kink in the interscalene catheter position. Myself and Dr. Winchester have really adopted the styleted catheter for using during our interscalene catheter placements. It's made it a whole lot easier to facilitate that Hickman flip that you've seen us do several times in previous videos. And it makes the flip just a whole lot easier by having that added stiffness to the catheter. However, there's not too many things in this world that are perfect, and this is one of those. Despite making it easier to do the flip, we do have one issue that we've had come up several times by doing it this way, and these styleted catheters tend to be more prone to kinking. This video is going to help troubleshoot that and show you what to do. It's very easily remedied when that does happen, and this is going to be a stepwise approach to what to do when that happens. So I hope you enjoy. And I feel a little pop as we get through the middle scalene muscle. So we're right against the plexus now. You can see the tip of the needle right along the plexus. And this is a dynamic process, so I'm continually scanning proximally and distally just to reconfirm in my mind exactly where that plexus is and confirm that we're in fact in a good location. I'm going to have our nurse inject 5 cc's here, and we're going to open up a nice pocket between the middle scalene muscle and the posterior aspect of the plexus. So go ahead, 5 there. Okay. You can see his C5 root has already started to split off a little bit. I think we'll be okay and get everything covered. But there's just a little bit of separation between C5 and C6 here, as you can see. Do another 5 cc's here. Got a very mobile plexus. You can see even with respirations, his plexus is swimming around a little bit. I'll do another 5 here. Continue to open up that pocket. We're going to use a total volume of 15 cc's with this block. So you saw the last few cc's there really open up that pocket a little bit better. So we're going to stop there at 15 cc's. I'm going to hand the probe over to our nurse Donna here. She's reaching underneath the non-sterile side of the drape and holding the probe for me as I stabilize the needle and grab the catheter. For these blocks, my preference is to use this styleted catheter. If you've watched our earlier videos, you'll see that we use the Hickman flip technique, and the styleted catheter really makes it a whole lot easier to do that. Again, the reason we do all this is just to keep everything posteriorly. So our nurse Donna is going to be holding that probe in place for me. So we're going to see, get a little better view of the needle. About there, and I have the catheter is going to be coming out over top of C5. As I advance it, I'm going to flatten out the angle and advance a little bit more catheter. You can see a little bit of a flip there. And I'm going to do a second flip if I can here, right along the plexus. The idea is just to get a little bit of slack within that space between the middle scalene and brachial plexus. That way, if it gets tugged on and all, it doesn't come completely out of the money spot there. It helps secure it, which, like we talked about earlier, is an important aspect of all this, making sure that it stays in place after we've gone through all this effort to put it in. We want to make sure it stays that way. So I'm going to start backing out the needle as I'm threading catheter through it. We're about 14 centimeters at the skin right there, which is a good amount of catheter in place. That should help secure it and anchor it as well. I'm going to take out the stylet now. You can see there's a little green piece right here. You just pull that out. Out comes that stylet. And now we have just an ordinary epidural catheter here. We'll take the needle off from there. Attach our alligator clip. And make sure that's properly seated. You'd be sabotaging yourself if there's a little bit of space there. So that looks like it's nice and secure. Snap that closed. Now we're going to test the position of that catheter, make sure it's in a proper location. This is just the lidocaine testo solution that comes with the kit. It's 1.5% lido with epi, about 3 cc's. We'll attach this syringe. And under direct visualization, as we're watching the spread in the ultrasound screen here, hopefully we can see that local anesthetic spread and push along the plexus. We're going to get our best view we can here. You see the plexus here, and we'll point that out again. Right here is the plexus. We scan just a little bit more proximally. You can see a glimpse of the catheter going in that area. There's the catheter. So that tells us we're about the right height in terms of where our catheter is located. So now we'll watch carefully. I'll have Don, our nurse, hold that view right there. Let's see, just a little bit lower, right about there. And hopefully we see those nerves push as we inject the local anesthetic. So here we go, 1, 2, 3. There's a kink within that catheter, so this is difficult to inject. It's really not going, no matter how hard I push, it doesn't want to inject. So this is not something we planned on, but definitely something that's worthwhile to show you. When this does happen, there's an easy solution to it. And what we do for this case is, as we're applying pressure to this plunger, we're going to slowly withdraw the catheter. So it'll be almost a loss of resistance technique. As soon as we feel that give, we know we've released that kink. So we watch here, we'll slowly pull it out, and right there, all of a sudden we've got that spread. The catheter, we started around 14 centimeters of the skin. We just had to pull back a centimeter or two, so we're still about 12.5 at the skin, which is certainly adequate, and it's an easy fix. So now we're back to the ultrasound view with the styleted catheter. Yeah, with that styleted catheter, it doesn't happen quite as frequently with a non-styleted catheter, but it still can. I've had it happen a couple times when I've done it with just the regular catheter, but especially with a styleted catheter. I'm not exactly sure why that is, but we've definitely observed that several times. Easy fix though. The majority of the time that occlusion lets up right around 11 or 12 centimeters at the skin. If by some chance that doesn't let up around there and you continue to pull it out, there's a small chance that you may need to end up repeating the procedure and just taking that catheter out and putting in another one. Occasionally it'll release around 7 centimeters or less. 7 is really my magic number. If it's less than 7 centimeters, I'm concerned that that catheter's going to get dislodged with any movement of the neck or any tug, so I would elect to redo it at that point. But this one, we still have a good 12 centimeters of catheter in there. Now we're going to confirm that it's in fact in a good position. So we go back to our ultrasound view here. We see our plexus, nice view of it there. So there's our stoplight. And if you watch, keep your eye right there. We're going to inject our test dose. Here we go, 1, 2, 3. And you see a nice spread of local anesthetic along that plexus. We opened up that pocket. You can see a little bit of air in there already. I'm going to inject a little bit more air just to help illuminate exactly where that catheter is. So I have a little bit of air in the syringe here. I'm going to turn that syringe upside down so the air flows to the top. And then as we inject that air, you should see a nice little burst in that pocket we've opened up along the posterior part of the plexus. So here comes a little bit of air on 3, 1, 2, 3. And you can see just a glimmer of that air. That again just helps us identify the exact location of that catheter and shows us that it is in fact in the correct position along the posterior aspect of the brachial plexus there. So everything here looks good. Finish it off with just a little bit more local, and that looks like a perfectly placed catheter. Okay, so to wrap up and summarize what we learned from this little video, the one major drawback to the styleted catheter is that it's higher incidence of kinkage. Fortunately, there's an easy remedy, as you just saw us do. By simply pulling back as you're holding pressure on the plunger, you use a loss of resistance technique, and as soon as that lets up, you should be able to freely inject once that kink relieves itself. Most of the time that happens around 11 or 12 centimeters of the skin. In those rare situations where it doesn't relieve or let up until you're further out of the skin, you may need to replace the catheter and repeat the procedure at that point. But that's very rare. I'd say that happens maybe 1 out of 15 times or so that we experience these kinks. So certainly not a major problem, one of the minor drawbacks of using the styleted catheter. Otherwise, again, it's something that we use on a regular basis at this point. The styleted catheter adds just a little bit extra cost, which can add up over time, but again, I think it's certainly worth it in my experience in doing these interscalene catheters to make sure that everything remains posteriorly and really facilitates all that facilitates the process of all that. So I hope you learned something from this video, an easy problem to remedy, and stay tuned for more.